So good afternoon, everyone. So I'll be presenting tPA where, when, and how I use it. How I use it intravitreal, subretinal, and recently I've tried suprachoroidal in one patient. When I use it, small submacular hemorrhages, I give intravitreal, then large submacular hemorrhages, hemorrhagic retinal detachments, suprachoroidal hemorrhage, and subsilicon oil pre-retinal hemorrhages. So small submacular hemorrhages you just displace using the intravitreal gas and tPA. This technique attempts to physically displace the submacular hemorrhage out of the fovea using expansile gas faster by liquefaction of the clotted blood using tPA. The dose given is 50 micrograms. The procedure is performed under topical anesthesia and involves an intravitreal injection of 0.3 to 0.4 ml of SF6. Most commonly I use SF6 and sometimes C3F8. A face down positioning is done for 1 to 3 days, and the advantage is that you can do it in OPD and there's a shorter displacement time. So this is one of the cases. There was a macroaneurysm which has led to the hemorrhage in all the 3 layers, and this was given this intravitreal tPA and gas was given post-operatively. Very fast. The action occurs very fast in this type of small submacular hemorrhages. I was able to displace of the hemorrhage, and this is another patient. This was, in fact, was the first case which I had treated of submacular hemorrhage with intravitreal injection and tPA. So large submacular hemorrhage vitrectomy with subretinal tPA. You use the small 41 gauge macro cannula nowadays, and this is how I go about it. So this was a large submacular hemorrhage.
85-year male presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCV. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment, and subretinal hemorrhage in other eye about 3 months ago. We plan to do vitrectomy with subretinal injection of tPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM peeling was done. tPA in the dose of 25 micrograms in 0.1 ml was injected subretinal using a 41 gauge micro cannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. A 20% SF6 gas was used as tamponade. Patient was advised prone positioning post-operatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.
And what we were discussing in the last case, this is a common complication that
This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of the 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 ml syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the PFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27 gauge vitrectomy was done without base excision. PPG was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. 40-gauge microcannula connected to the subretinal injector was used to inject tPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6 by 12 at 4 weeks post. Common complications.
So this was a case of a large hemorrhagic retinal detachment, and there was no breaks. Only this large submacular hemorrhage secondary to IPCV was seen. And this patient I gave intravitreal tPA 1 day before I took her up for surgery. And next day I drained the hemorrhage externally, not going inside and doing the vitrectomy. And this is picture on the left side is 1 day post-operative. And I was almost able to drain most of the blood in this eye. Otherwise I have to go inside, create a large retinectomy and remove the blood. So this is another option where a tPA can be used. Then for suprachoroidal hemorrhages, this was a 56 years female, 2 weeks post-cataract surgery. A suprachoroidal hemorrhage had occurred intraoperative. The best corrected vision was PLPR accurate. The patient also had a retinal detachment with giant retinal tear, and retina was lying in the pupillary plane. So we can't delay the surgery for more period than this period, 2 weeks, although 2 weeks is also good enough that the clotted blood liquefies and you will get, but precautionary, I just chose to give a suprachoroidal tPA 24 hours prior to surgery, and then took the patient up for surgery. And this was the surgery that was performed.
Giant retinal tear and PPR underwent vitrectomy 3 weeks after her cataract surgery. Cannula for infusion was placed intratemporally. Endo-illuminator was placed inside the cannula. White reflex indicated correct placement of cannula in the vitreous cavity. 4-port vitrectomy with chandelier in infernasal quadrant was started and anterior vitreous was removed. Retina was seen in the iris plane. Subarotemporal cannula was seen to be in suprachoroidal space. Tissue surrounding the cannula was dissected to bring it in vitreous cavity. Vitreous adhesions to iris were removed and anterior vitrectomy completed. Core vitreous was removed to reveal the posterior hyaloid. Triamcinolone-assisted induction of PVD was done and vitrectomy with base excision was completed. Subretinal blood was slowly aspirated using silicone tip backflash cannula. Remnants of capsule were peeled and removed. PFCL was used to stabilize posterior retina and ILM was peeled under PFCL. Subretinal bands were peeled to take care of fixed folds. 26-gauge intravenous catheter was inserted in suprachoroidal space to remove the residual hemorrhage. After confirming the tip to be in right place, the metallic fillet was removed, leaving the plastic cannula behind, and blood was drained out. Retinectomy was done to release all traction on retina. PFCL was used to flatten the retina and 360-degree peripheral barrage laser was done. A direct PFCL silicone oil exchange was done.
So this is the final post-operative pictures of this patient. So I have done only one case in which I have used this suprachoroidal, but I feel it may be sometimes be useful when you can't wait for longer to a time like 2 weeks or 3 weeks in the presence of a retinal detachment or kissing choroidals, which may cause very PVR very soon, rather than if we wait, we may even lose the case at that time. So in those cases, it can be given a try. Then subsilicon oil pre-retinal hemorrhage. Again, I've used in one case, but I did not have a favorable outcome. Actually, I missed that there was still a little bit of detachment present below in that patient. And the clot definitely got lysed, but the blood went subretinal and through the open break which was present. And it also scattered all around and retina could not be settled again. Thank you.
Can I say something? Like
Sure, sir, please.
Especially submacular hemorrhage, we should not remove the ILM just before giving the subretinal tPA. As subretinal tPA sometimes cause this macular blowout, foveal blowout. So if you have the macular formation postoperative period or during the surgery, you have to sometimes do the inverted ILM flap technique. So if you don't have the ILM at that time, so your macula will not be closed. So that is the, I think we should preserve that this ILM as just
Yeah,
as a
you are
routine
right. The
submacular
only
surgery.
thing is like if this macular blowout occurs and there's a macular hole formation, it is very difficult to remove the ILM at that stage because sometimes there are air bubbles below and the retina gets raised. It's very difficult actually at that very sitting. You if you do it, try to
That's
do it.
that's yes. That's why I
And
was telling
in one of those
during,
cases,
during surgery, during the foveal blowout, you can just just touch your this soft tip cannula just overlying the macular hole to just oppose the hole margin. So if the fortunately hole is closed, that's good enough. If you are not closing in the postoperative or there is reopening of the macular hole, then you can even do the ILM surgery after the in post-op period after 2 weeks
yeah,
when the most of the blood has gone, because you should not take the subretinal tPA out from the subretinal space, as it will it will not serve your primary purpose.
yes.
So tPA ILM, I think it should be preserved routinely. Whatever, sir, what is your
That's what I was talking, that was it a prophylactic removal or just because it is once
So,
you coincide with
so
that,
one
you
thing
remove
was like if the blood is multi-layered, like there was a sub-ILM blood, then there was an intraretinal hemorrhage, subretinal hemorrhage, as in that macroaneurysm
that patient
case.
there was no macular.
Pardon, sir?
In the patient where you showed
One
that
patient, the earlier one, there was not there. But actually, there was such a large submacular hemorrhage, I thought I'd better remove the ILM.
the question was in the first video you showed,
Hmm?
where you gave intravitreal tPA. So I would have done only pneumatic displacement and anti-VEGF.
Without the tPA.
Yeah, intravitreal.
Yeah, that's also an option.
Yeah. The other option is that we often forget that these patients, a lot of them are IPCV patients.
Yes, sir.
A lot of them. So post-op, recurrent ILA injections are required.
Yes, sir.
It's not that because we are doing a mechanical job only. We
Yeah.
remove the blood and put the gas or pneumo displacement. But we often forget that these patients do require.
Yeah, the underlying pathology needs to be taken care of post-operatively. That
Because I
has
have
to
one
be.
patient whom I ultimately injected oil, but with the oil also I keep giving
In-
this ILA injections.
Yes.
Sir, I want to say one, like rather than ILIA, you can choose Brodoshivo, because ILIA is the molecule size is quite large, and if you give this thing, I have done in one study and I've already sent for the publication. I don't know whether it will be published or not if it is accepted by IGO. So the thing is, Brodoshivo is the very smallest molecule, and if you are injecting in a vitrectomized eye, it will penetrate so faster. It will there will be no time for the washout from the vitreous cavity. So it will go directly into the subretinal space within 6 hours.
And ILM
So-
peeling also helps in that also.
Yes,
Faster
but it's true. But macular formation, if you face in postoperative, you don't have any tissue to close it. You have to choose the either anterior lens capsule or amniotic graft or autologous retinal graft, all these things. So ILM is the basic thing for to treat macro, to close macro. Yes.
Subretinal tPA, you often require multiple places. You don't inject one
Yes.
place. Other.
Mm.
So at times you have seen, it regurgitates out small fluid, and then you do airflow exchange. It may be more is coming out. So do you think that we should inject more, or because I have not done it, but in my we often see our videos post-op. So I saw video it has regurgitated.
Some
Yeah,
amount.
some amount does come
Yes. Initially, sir, because there is no space, there is potentially where you are injecting, the choroid is totally opposed to retina, and you are not injecting in the area directly under the hemorrhage. You start somewhere away from it, and that is the reason sometimes it just comes out and then it creates a plane and goes inside.
So the idea is to basically create a cleavage plane first, And once there is a cleavage plane formation, you will see less amount of regurgitation and more amount of bubble formation with the kind of injection. As you keep injecting, the bubble formation rate increases, and there you will see a lesser amount of regurgitation, unless and until that bubble is fully stuck with a clot formation. In that case, you may see a slight amount of regurgitation, but even in that case, you may inject slightly more drug, because that regurgitation doesn't like negate the dosages that we're trying to put in.
Some people have described, subretinal along with air, along with the air bubble, and along with Avastin also, everything, cocktail kind of cocktail.
Yes, subretinal cocktail of anti-VEGF, this thing, because in vitrectomy side, most of the anti-VEGF will not work, apart from very few options. So you can give even biosimilar ranibizumab also, Avastin also, or the original drug also.
So I have
So
used
these things-
subretinal
Yes,
air.
cocktail, anti-VEGF, subretinal tPA and air.
But
Yes.
sir, in my practice, I've so but in my limited practice of 100 injections that I have done in past 3 years, sir, that I haven't felt the need to make inject air for a cleavage plane generation. I haven't felt the need. I mean, its idea is
It's not for the generation. Like I was explaining,
yeah.
it is for the, like, when you are giving tPA, the blood will lysed. So lysed blood, that means the RBC will
It'll
be
gravitate.
settled down inferiorly, and if you are injecting subretinal air, that will, due to the buoyancy factor, it will go up, and it will the gravity
It's settled
situation, the
down.
RBC will go down. It will make the foveal area clearer.
Yeah.
So if the distribution of hemorrhage is just beyond the arcade, superior arcade, this is the ideal situation. You just injected the tPA and anti-VEGF, and after some time subretinal and the volume 0.05 cc of this thing. You have to very restricted volume, that tPA, and 0.05 cc of anti-VEGF and 0.03 cc of air,
air.
not more than that.
Yeah,
That is
sir.
the-
Sir, but like that is the rationale. If I will ever use a subretinal air, I will use it
Yes,
for.
yes.
But what sir was saying was to create a cleavage plane. So that was what I was telling her. For cleavage plane formation, probably I'll not use an air. But with his rationale, probably I will try to give it a shot to see if there is a better clearance with it.
So I have used subretinal air in patients who are not able to maintain post-op proper positioning. So you just give air and then you exchange it with gas and advise the patient to propped up position you can give.
Propped up position
And
initially.
yeah, and then the problem with subretinal air is, like Dr. Subhendu said, you have to give a very titrated air, because if you give more volume,
More
what happens is the air just cleavages the retina and goes up,
goes up.
and then causes, maybe sometimes it causes retinal detachment
While
also.
the patient is lying down, while the patient is lying down, the air will go up. But when the patient is in the propped up position, again it will come back in the macular position. That I have by the optos, I have done it immediately in post-op period, that peripheral air has again come to the macular area. Yes, 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 that's true. Yes, yes, it will accumulate gravitate because of the change in the surface tension. The air will come again into the macular.
So one more problem with subretinal air injection is that the technique that I showed for a controlled dose to eliminate the entire learning curve, I believe, although I haven't tried, but going by the physics and mechanics of it, I believe that injecting the air via that mechanism also will then have a risk of causing a blowout, because I don't know how much of viscosity, how much of air viscosity will be able to prevent a sudden injection rather than just a controlled injection. So that controlled injection, probably I will not be able to achieve with that mechanism that I showed also. But I'll have to
avoid the sudden injection. You should avoid it. That's why I developed one micro VFC tool to just graduated injection of in a
Air.
gradual manner, gradual increase, very gently.
Yes, sir.
Thank
Thank
you.
you, sir.
Thank